mentor പുതിയ കുട്ടിയാ?
I'm a student. Don't say sir. Please, I request you. I am a regular student of yours.
Start ചെയ്യണോ വെയിറ്റ് ചെയ്യണോ 2 മിനിറ്റ്?
നമുക്ക് പതുക്കെ തുടങ്ങിയാലോ? ലേറ്റ് ആക്കണ്ട.
So good evening all to the IEP Kerala and IEP Trivandrum PG Club, and once again welcome to our IEP PG Club platform, and we are an interesting case discussion today. And so for the opening remarks, I will invite Dr. Neeraja, the President of IEP Kerala, for the opening remarks.
So, respected teachers, starting from Srinivasan sir, Purushothaman sir, and Devshan sir, Darli madam, Joe sir, and all my friends here. So this is yet another happy moment. We are having this PG Club program now for more than, I think this is the third year actually, because it was started from the time of Joe sir's presidency. And this year also we are doing it with a lot of additions, like we are having lectures by senior teachers, OSCEs, and even theory paper discussions, etc. And this edition is actually organized by the IEP Trivandrum branch under the leadership of Kalpana madam and Srijit. And we have a very eminent teacher this time, a teacher who is very friendly to students, as well as who is having a kind heart. And we need to learn the counseling skills also from sir, I should say. So we have Hariprasad sir as the teacher for today, and Dr. Anuja is presenting. Welcome, Parvati madam. So without any ado, I am handing over the mic to Srijit again for the proceedings. Thank you all.
Okay, thank you, sir. Now I welcome Dr. Joe sir, the NNF president and the coordinator of the Presidential Action Plan, for a few words, sir. Joe sir.
Good evening to all. I am academic program. I request to continue the program.
Okay. Okay, thank you. Then we will straight away move to the academics, and I will introduce Dr. Neeraja, is the assistant professor in pediatrics and at SATH Hospital, and Dr. Neeraja is the mentor for Dr. Anuja, and Dr. Neeraja will introduce the speaker, the case, as well as the discussion. Over to Dr. Neeraja.
Good evening all. I am Dr. Neeraja. I am the assistant professor in SATH Pediatrics. Today we will have a case presentation on the system of central nervous system. It's a usual and very important exam case, as well as a CNS case that we usually encounter in our wards and our usual rounds. So this case will be presented by Dr. Anuja, our postgraduate, and this will be discussed and chaired by Dr. Hariprasad. So to you, Anuja, and Seth.
Okay, so thank you, Neeraja, and thank you all leaders of IAP. And I think we have got a galaxy of teachers starting from Srinivasan sir, Parvati madam, Dr. Darli, Purushothaman sir, and the Keshavan, everyone. So I think I am also sitting here as a student, and I request all the teachers to contribute so that we can have a very fruitful discussion on this common scenario, and we'll discuss not only the theory but also some practical aspects, so that the children, the young pediatricians will be able to rehabilitate them to the maximum. So I think I request all the teachers to contribute, and also to correct Anuja as well as myself whenever needed. So I think we can go to the presentation. Over to Anuja.
Good evening, respected sir and madam. Today I will be presenting a CNS.
Anuja, make it full screen. Make the
Sir, the full screen slideshow.
ഡബിൾ ക്ലിക്ക് ഫുൾ സ്ക്രീൻ എന്ന് കാണുന്നുണ്ടായിരുന്നു. ഡബിൾ ക്ലിക്ക് എന്ന് ഷെയർ ചെയ്ത ഉടനെ തന്നെ നേരത്തെ ട്രൈ ചെയ്തിട്ട് പക്ഷെ നടങ്ങുന്നില്ലായിരുന്നു.
Slideshow. Slideshow തന്നെയാ sir.
എല്ലാവരും അടുത്തിരിക്കല്ലേ, കാണാൻ പറ്റുമല്ലോ, കുഴപ്പമില്ലല്ലോ.
Sir, start yet.
Okay.
Start.
Continue.
Good evening. I'm Dr.Anuja Biju, Junior Resident Department of Pediatrics from SATH Hospital. I'll be presenting a CNS case discussion today. The patient is Amjit, who's a 5-year, 8-month-old male child. His date of birth is on 6th November 2000.
Slide move ചെയ്യുന്നില്ല.
Sir, move ചെയ്യുന്നില്ല.
ഓഫാക്കിട്ട് ഓൺ ആക്കൂ.
ഇപ്പൊ മൂവ് ചെയ്തു.
He's from Koni, Pathanamthitta, and the date of admission is on 18 July 2025. Date of examination is on 23rd July 2025. Informant is mother, so the history is reliable. Chief complaints: the mother presented with complaints of delay in attainment of milestones since birth. History of present illness: since the child has developmental delay since birth, I would like to start from the antenatal history. Antenatal history: the second child of non-consanguineous marriage, spontaneously conceived at 22 years, and paternal age was 32 at the time of conception, and conceived 1.5 years after marriage. Pregnancy was confirmed by urine pregnancy test. An antenatal case was registered at the government hospital Pathanamthitta, and first trimester, no periconceptual folic acid was taken, and folic acid was taken only after confirmation of pregnancy. Dating scan was done at 10 weeks and it was normal. No history of fever with rash, neck swelling, or any burning micturition. No history of radiation exposure or any drug intake. Second trimester, quickening was felt at 5 months of gestation. Around 6 months, the mother appreciated decreased fetal movements associated with lower abdominal pain. Per vaginal examination was done. It was found to have bleeding PV and was referred to Kottayam Medical College. Mother received IV medication, after which symptoms subsided and appreciated normal fetal movements. And anomaly scan was normal. And the mother had gestational diabetes mellitus and was on medical nutritional therapy. TD 2 doses was taken. No history of any gestational hypertension or hypothyroidism. Iron, folic acid, and calcium was taken. Third trimester, the mother had history of anemia and received parenteral iron therapy thrice during the third trimester. Third trimester scans were normal. There was no evidence of fetal growth restriction. Liquor volume was adequate. No abnormal presentation. No history of any reduced or increased fetal movement. No history of UTI. Weight gain was adequate. But the mother developed leaking PV 5 days prior to the expected date of confinement. And natal history: since the mother developed leaking PV 5 days prior to the date of confinement, he was taken to the local hospital immediately and was informed that the child's head had already descended and delivered by normal vaginal delivery after 4 hours after reaching the hospital. Birth weight was 2.6 kg, AG baby. The baby cried soon after birth. Breastfeeding was initiated soon after birth but had difficulty in sucking. Postnatal history: on postnatal day 1, baby was found to have difficulty in sucking. The mother noticed that the baby was able to latch well onto the breast but was unable to suck effectively, hence started on express breast milk via NG tube and was shifted to ICU for observation. There was no history of any poor activity, lethargy, vomiting, or abnormal movements. There is no history of any sucrose cycle or bluish discoloration of skin or mucous membrane. And on the same day, the mother was informed that the baby had one episode of hypoglycemia, but was resolved after giving express breast milk via NG tube. And the baby passed meconium and urine within 24 hours of life. And on postnatal day 2, the child developed jaundice and was kept under phototherapy for few hours. But the mother mentioned that the child was kept under observation in NICU for 5 days and did not have any infection, did not receive any antibiotics, and continued on express breast milk via NG tube feeds. And mother noticed inconsolable cry since birth, and the baby was started on Gokarna feeds on postnatal day 7 and shifted to ward and discharged on postnatal day 9. And the baby was continued on Gokarna feeds at home, was having adequate weight gain. But on postnatal day 28, the baby developed fever followed by tonic-clonic movements of both the upper limb and lower limb lasting for 5 to 10 minutes, taken to local hospital and received IV medication for the abnormal movements. And the baby was admitted in NICU for observation and was noticed to have stiffness of both the lower limb and started on physiotherapy. According to the mother, EEG and MRI was taken. Both were abnormal. He was given anti-seizure medication for 5 days and was stopped. Continued on Gokarna feeds, was having inadequate weight gain and was started on supplements and formula feed. Discharged after 1 month and was advised to continue physiotherapy but was not advised any anti-seizure medication. At the same time, the mother noticed that the child had eye contact, responded to sounds by crying, and there was inconsolable cry in the baby. Head control was not attained by 4 months. Physiotherapy was continued from a private hospital at Pathanamthitta but was irregular due to personal issues and continued on Gokarna feeds. The child was started on complementary feeds at 6 months, started on initially on ragi and banana powder given via cup and spoon. Later, around 8 months of age, started on rice feeds, which was grounded. But the baby had no difficulty in swallowing, or there was no history of regurgitation of feeds, but there was drooling of saliva was present. Head control was not attained. The child made few cooing sounds, was able to follow objects, and there was high contact with the mother. The mother noticed stiffness in both the lower limbs while changing diapers. There was no any hand preference or paucity of limb movements. Physiotherapy was continued from a government hospital in Koranjeri, but the growth was inadequate. At 1 year, the child attained social smile, started on family pot diet given in mashed form, and child was able to swallow without any difficulty. There was no prolonged feeding time which was required. The child spoke Amma and Acha and waved bye-bye around 2 years of age. The child was unable to sit with support or roll over. At 2 years, the child was admitted with lower respiratory tract infection, managed with IV antibiotics, and discharged after 5 days. There is no history of any aspiration of feeds. At 3 years, the child went to Anganwadi twice weekly. He was able to hold a pen and was able to scribble and respond to other children by laughing. Now the child is able to scribble, reach for objects with one hand, plays with blocks, but unable to make a tower, makes cooing sounds, laughs, tells Amma, and respond to sound and follows objects. And now he goes to a government school, Pathanamthitta, for children with special needs. He undergoes physiotherapy, oromotor stimulation exercises, visual and hearing stimulation exercises done at the school. And the mother gives history of intermittent twisting movements of the limbs. There's no history of any sleep disturbances or constipation or bed sores or any urinary tract infection or hip dislocation or fractures or behavioral problems in the child. There is no history of any drooping of eyelids, abnormal eye movements, nystagmus, or facial asymmetry or incomplete closure of the eyes or nasal regurgitation. There is no history of any asymmetry of the limbs or early hand preference. There is no history of cyanosis or excessive sweating over the forehead. No history of unusual odor of body or urine. No history of any episodic symptoms which is precipitated by infection. And no history of abdominal distension or skin changes.
Okay, and I think we'll do one thing. We'll just discuss the history this much, and then we'll proceed. Okay. So I think so. The child is 5.5 years, and you are presented starting from the alienated. You said at 10 weeks ultrasound was done. It was revealed as normal, isn't it?
Normal, yes, sir.
What are the measures you will look to say it is the growth is normal at 10 weeks?
Second,
10 weeks. What parameters will look up to 13 weeks for the
So the first trimester.
Anybody? Yeah, look for the CR. It's a crown, isn't it?
Crown rim length.
Okay. Yeah. So in the first, that is in the up to they assess the crown rim length and then say whether the growth is normal. And the second trimester and third trimester, what will you look for to assess the growth?
Third trimester, look at
Suppose,
look at the femoral length.
Yeah, femoral length.
Also
the head circumference. Okay, that's. I think you should be very clear in that. Okay. So in the first trimester, you look for the crown rim length, and in the second and third trimester, you can look for the head circumference on the femoral length. Okay. So they said that was normal. Then they said, then you said, at 6 months, mother felt decreased fetal movements, isn't it? And they were a child. She was referred to Kottayam Medical College. That's what he said. So, what are the points you should think in your mind when a baby, when the mother complains of decreased fetal movements?
Whether there is any history of bleeding, PV, or rupture of membranes, or any false abdominal pain, false.
They will present as decreased fetal movements. Anybody? When a fetus is and decreased fetal movements, what are the points that should come to your mind?
Hypotonic child.
Yeah, send it. The baby is hypotonic. That means you must keep in mind the possibility of a condition like myopathy or muscle dystrophy. Send it. Okay, so that's very important because when you have a baby with a fetus with decreased fetal movement, I think you should plan the pregnancy or the delivery in a major center. Yeah, that is important. So I think as pediatrician, we should be aware of the condition of the mother also, but the anterior mother. Okay, so that's very important. Okay, then in Kottayam MCS, they evaluated the child and then they were sent back. And we also said the mother is also having gestation diabetes and mother received 3 doses of iron therapy. Said it, IV iron to correct the anemia. Okay, so what does all this indicate? Do you think that the pregnancy is a normal pregnancy or is it a high-risk pregnancy?
So since the mother is having risk factors like anemia, gestational diabetes, it is definitely a high risk. There is a risk of.
Yeah, I think so. Here, I think she had 1 abortion. That's what you said.
Yes, 1 abortion, first trimester.
1 abortion, and the mother complains the decreased fetal movements, and she is also having diabetes mellitus, and she is also having severe anemia, and so ideally the delivery should have been planned in a higher center where facility for resuscitation should have been done, isn't it? I think that is probably the first message I think we should take home. Okay, but unfortunately, she was referred back to local hospital where she delivered. And is there any other point in the just before pregnancy indicating that a child had some child is likely to have some problem? He had 5 days of leaking. That's what he said, isn't it? So what other questions will you ask in such a situation? What other questions you should ask the mother?
So leaking, whether there is any bleeding.
Bleeding, then.
Or any decreased fetal movements or any history of infection, chorioamnionitis, UTI.
Yeah, that is very good. Yeah, that is it, isn't it? So you should always ask for presence of fever, isn't it? But you didn't mention that. I think you should have mentioned no associated fever, no issue of any foul discharge, etc. That means indicating infection, isn't it? And that itself is another indication where the baby or the fetus is likely to be in distress. Okay. So that is regarding the antenatal. And then you said baby cried soon after birth, but baby was not able to suck at the breast. Okay, what could be the problem? What are the
Difficulty in
problems the
sucking
female is sucking for a
could be
moment?
because due to improper latching, that is, or it could be due to encephalopathy in the child, or
Okay.
could be due to any congenital cyanotic heart diseases or any congenital heart diseases that the child was not able to suck, or it could be due to any infection, sepsis. Uh, Child was having
Do you
poor
know that
activity.
cyanotic congenital heart disease will present as failure on day 0 itself? Is it common?
No, sucrest.
No, the successor cycle appears later, isn't it? Once the baby is around 45 weeks, sorry, 45 days, around 6 weeks, isn't it? So on day 0, baby is not sucking, what will you suspect? One, as you said, this could be probably child had baby had mild respiratory distress, isn't it? Even though when the baby cried, baby is not able to suck at the breast. Second, you said there is decreased fetal movements. Again, there is a possibility of a muscle problem where the baby is not able to suck.
That's a problem.
Isn't it? Okay. So what are the other questions you should ask here? Keeping in mind decreased fetal movements. It's a male baby. Others can also contribute. I think
So
we
one
should
more.
not ask Anuja more. Regarding the baby, we'll come to the family history later. A baby with a newborn, a fetus with a history size of decreased fetal movements. Yeah, you should ask for the activity, isn't it? General activity of the baby. The cry of the baby, even though the baby cried, whether it was a very good cry or it was a very weak cry. Then, did the baby have any respiratory distress? Isn't it? And it's a male baby, so you can also ask for undescended testis. Okay, because all this indicates probably baby is having an underlying muscle disorder. And again, the myopathic babies are likely to have small funnel-shaped chest, isn't it? And all mothers will completely scan their newborn baby, isn't it? So you can ask for such leading question, and if that is present, that indicates that the baby is probably having an underlying muscle disorder, probably a myopathy. Okay. So I think you had to include these questions also in the history. Okay. Then you said baby had inconsolable cry. Was it from the newborn period itself
The
or
newborn
only
period
on
itself, like
no?
from
Okay.
the newborn
So
period
what
itself.
is in your mind when a baby is having inconsolable cry?
It could be
Am I
due.
audible?
Yes, sir.
Heavy rain here. കേൾക്കാമല്ലേ ഭയങ്കര മഴ.
So it could be due to any sepsis or any infection like meningitis.
Okay. Again, infection.
Irritable.
Again, it may indicate hypoxia or hyperischemia, or again, as everybody is telling, it can be a part of infection, it can be hunger cry, it can be meningitis, or it may be indicate a cerebral irritability as a part of hypoxia. So again, I think you have to ask some questions to differentiate whether it was a suggestive of a sepsis or it was suggestive of an encephalopathy or something else. Okay. Again, intraoperative bleeding, again, they can present as intraoperative cry. So I think you should have elaborate little more details here also. Okay. Now, you said baby had fever and seizure at 28 weeks. So what is the first possibility in your mind? A newborn baby developing fever and seizure on 28 days.
So it could be due to late onset sepsis, meningitis.
Yes, the meningitis, isn't it? So did the baby was subject to a lumbar puncture?
No, the child did not undergo lumbar puncture.
So I think again that is so. Earlier we said the delivery should have been in a tertiary care center, and here a 28-day-old baby is having fever and seizure, and evaluation for meningitis was not done. Again, that is a problem. We don't know whether it was significant or not, but still, again, we had to think of a meningitis. Okay. Right. Now then you said baby was having stiffness and child was suffered subject for physiotherapy. So will you advise direct physiotherapy for a baby, for a 20-day baby with stiffness? What is your take?
Yes,
Or
sir.
will you evaluate?
Sir, early physiotherapy is recommended because
Definitely early physiotherapy is recommended. But the thing is that you have to grade the stiffness, isn't it? Okay, we'll discuss that later. You have to grade the stiffness. Definitely early simulation is needed. You have to start physiotherapy, but always it's better to grade the stiffness and then start the physio. Okay, now I think we'll come back to that area later. Then, will you ask any more questions to the mother?
So it could be due to even hypoglycemia because medical supplement.
Okay.
Then
What are the other questions to be asked at this
electrolytes.
center? Now we have reached from antenatal, we have reached up to 28 days, and you said child is start on physio. What other questions to be asked? You said what was the upper limb? What was the movement of the upper limb? Whether it's completely normal or a little bit abnormality was done? Was there?
Mainly it was only in the lower limb. The mother didn't notice. It was the hospital they noticed.
You said the baby was admitted in newborn nursery. That's what you said, isn't it?
Yes.
Okay. Suppose you are working in the newborn nursery. What scale will you apply for such a baby?
So either Pretzel's or Heinz. Hammers. Sorry.
You are this baby is admitted in your newborn nursery and you are planning to evaluate the baby. And what CNS exam for discharge can be done and which can be monitored also.
Sir, Hammersmith
Am I
neonatal
clear?
scale. Neonatal scale.
Yeah, very good. That is a HNNE, isn't it? HNNE, that is a Hammersmith neonatal neural exam. I think we should make it a practice to apply this HNNE to all newborns, especially newborns at risk on discharge, because this can be followed up, isn't it? So this scale can be followed up for the prognosis. And suppose the mother is intelligent enough, what advice will you give the mother also on discharge? One, you can do this HNNE, and what advice you will give the mother? Suppose that's a clue. She has got a smartphone with her.
Hello.
You can tell the mother to record the video. That is general movement assessment, GMA. That's very important. He said that the general movement assessment is practically equivalent to an MRI at 3 to 4 months, isn't it? Okay, I think these are very, very basic recommendations that should be given, that should be done by a pediatrician when you are working in a center where newborns are managed, isn't it? I think so. We should have recorded HNNE, and we can ask the mother to have a video recording of general motor assessment. That's called GMA, and we can use this for comparison. Okay, right. Now you said okay. So anything else? So after that, child was put on physio. Was the baby put on any drugs or only
Not
physio?
only drugs, only physiotherapy, sir.
Only physiotherapy. Okay. So that also we should mention. Even till 5 years of age, even though child has got increased tone and the child was put on any drug. We'll come to the discussion later. Okay. Are you happy with the follow-up or suppose you are the treating doctor? Will you advise any other evaluation for this baby other than advising physiotherapy?
So then visual hearing.
Yeah, very good. Yeah, that isn't it. Always we should assess the vision and hearing. That's very, very. You didn't say anything regarding that vision and hearing.
That was not asked to follow. Sir, they were not advised any
That was not okay. You can specifically say that vision and hearing assessment was not done, isn't it? Okay. Now, will you ask any other question to the mother? They are coming from Pathanamthitta. Where is the Pathanamthitta from Trivandrum? What's the distance of Pathanamthitta from Trivandrum? What's the significance for this family?
So it is.
Anyone? 40% of pediatrics is social pediatrics, isn't it? So we have to be a socially committed person to be a good pediatrician. So they are coming from nearly about 150 kilometers away for evaluation. So it is our responsibility to evaluate the child completely and make a complete diagnosis and plan follow-up. That is important. Okay, right. Have they got an MCP card? You didn't mention anything regarding the follow-up in the community. How will you follow up such a baby in the community?
Sir, you must follow them according to American Academy of Pediatrics. You should follow them at there is the home-based newborn care, as well as there is the 9th month, 18th month, 30th month. You must follow up for any developmental abnormalities or any developmental milestones, whether they have attained.
They have got the MCP card with them?
MCP card is there with them. So regarding for the vaccination, they have the
Only
card.
for vaccine? Okay.
They
What is
have
HBYC?
Sir, it's home-based
HBYC. Yeah, home-based.
care of.
HBYC is home-based young child, home-based young child, isn't it? Where ASHA worker will follow these babies. Okay. Okay. So I think the point is that when we discuss such conditions, we should always bring in all the facilities that is available in the society also. Okay. Because if we follow these babies like this, we will be able to pick up more problems and we will be able to go for early stimulation. Right. Now we'll continue. So any other comments from any teacher, sir? Srinivas sir, Purushothaman sir, Darli madam, Elsworth madam? Any other comments or we shall proceed?
Srinivas sir, any comments, sir? Sir is there. Sir, unmute, sir. Srinivas sir, unmute. He's talking something.
Why me, sir? You are there and this thing. I only wanted to tell the first beginning. Nobody should identify somebody as a neurology case or something. They should say neurological symptoms, presenting the neurological symptoms. Yeah, they should not, because it can be a metabolic condition, it can be something that is because PG level we must not say identify it as one particular organ. It can be multiple organs or something. That is the only this thing comment I made. I hope many of you may agree, some of you may not agree. Thank you.
Okay.
Anuja, in the presenting complaint, as sir said one point, the thing is development delay since birth. So you need to tell only development delay.
Okay.
So that word is better avoided. Development delay since birth. Since birth part is better avoided. Okay. So the whole purpose of the history in a development delay is to answer sequential questions. Okay. So basically, is there a delay? So there can be a situation where pseudo situations, just other anxiety. That is one thing. In this case, no doubt there is a significant delay. Then to what extent is the delay and what is the spectrum of the delay? That also we have mentioned. The third thing is there any regression? In this case, there is no regression. So it's a static type of a disorder that is established. So out of this thing, you need to answer, is it a CP or other reasons for static disorders? So CP mimics. So in this case, there are different insults starting from the antenatal period, natal period, postnatal period, which Hariprasad was detailing very extensively all these things you discussed. So in this case, that is the point for
Okay, we'll proceed.
Next is developmental history, gross motor, partial head control attained at 2 years, developmental quotient 12%. Fine motor with palmar grasp at 3 years, development quotient 16%.
In the previous part, I noticed your development history. There was some missing in the gross motor part. Okay, there were delay up to head control and all up to 2 years. And after that, you are concentrating more on the fine motor, language, the feeding and all. But the gross motor, the next moment you said the child is now going to schools. So what was the gait problems, and the gross motor part in that part was a little missing while you're talking about the developmental part. Okay.
Language, hooing by 6 months, speaks Achan and Amma by 2 years, development quotient 38%. Social and adaptive, social smile by 1 year and waves bye-bye by 2 years, development quotient 38%. Vision and hearing follows moving object and turns towards the source of sound. So there's global development delay, and since it's more than 5 years, they can be intellectual disability is present. Next is dietary history. The child was on breast milk and formula feeds via Gokarna feeds till 6 months of age. Was started on complementary feeds since 6 months of age. Food was grounded till 1 year. Now is given family pot diet given in smashed form. And diet is deficient in fruits, green leafy vegetables, and dairy products. The required calorie intake is 1350 and protein of 20. His intake is only 815 gram protein, deficit of 550 kilocalories, and protein of 5 gram. Immunization history. The child was immunized according to the national immunization schedule, and last vaccine was taken at 5 years. No optional vaccines were taken, and no adverse events following immunization, and BCG scar was present. Family history. The child is a second child of non-consanguineous marriage. There's history of first trimester abortion in the mother. It was a missed abortion. And the father expired at 36 years, 2 years back, due to alcoholic liver cirrhosis. And there's history of seizures among the paternal cousin, who is now 29 years, now not on any medication. And no history of any intellectual disability or sudden unexplained death among the family members. Socioeconomic history. They live in a Pakka house with 4 family members. The father expired at 36 years. Mother studied up to 12th grade and is a sales worker. Is a monthly income of about 5,000. And according to modified Kupuswamy scale, it belongs to the upper low socioeconomic class. So it's a 5-year, 8-month-old male child, second child of non-consanguineous marriage with first trimester abortion in the mother, with history suggestive of perinatal insult and poor sucking since birth, presented with delayed attainment of milestones since birth, history suggestive of intellectual disability, increased tone abnormalities, abnormal movements, but there's no any feeding difficulty, no gross vision or hearing impairment.
Okay. I think Purushottam sir was mentioning about the CP mimics, isn't it? So what are the other questions will you ask when such a child baby is pursuing with a developmental delay? Keeping in mind the possibility of a CP mimic. And
Sir,
what are, you can mention 1 or 2 conditions also.
So you can ask about history of any lethargy, vomiting, regression of milestones, or
Okay.
any history of any ataxia or decreased tone, or it can be history of any abnormal eye movements, or any. It is. So it can be other CP mimics include conditions like MSUD, leukodystrophy, urea cycle defects, arginase
Okay.
deficiency. Yeah,
Okay. Right. And are you happy with just saying that the vision is, you said vision is okay, isn't it? No growth, vision and hearing abnormality, isn't it?
Yes.
Okay. So what is the most common visual problem that can occur in a baby with this type of presentation?
Cerebral visual impairment. Or
Yeah.
screen.
Hmm?
Cerebral visual impairment.
Cerebral vision, yeah, that is very important, isn't it? That means even if it appears that the vision appears normal, the baby may be having significant visual defects, isn't it? That I think all parents should keep in our mind. Okay, right. So I think we'll come to go to the examination.
On examination, general comment: the child is awake, interactive with intermittent dystonic movements. A posture: the child is lying on bed with arms adducted, elbows flexed, and hips and knees flexed and adducted. Vitals: temperature is 90 degrees Fahrenheit right axilla, respiratory rate of 26 per minute abdominothoracic. Pulse rate was 90 beats per minute, normal volume, regular rhythm. All pulses fell bilaterally equal, no radial or radiofemoral delay. And blood pressure was 90/60 in the left upper limb in supine position. Saturation is 98% in room air. No history of pallor, icterus, cyanosis, clubbing, lymph node enlargement, or edema. Head to foot examination. The head appears small. Hair: there is no alopecia or hair color changes. There is no facial dysmorphism. No signs suggestive of vitamin A deficiency. No history of cataract. No nystagmus or squint. Ears and nose appears normal. Oral cavity, dental caries present. Tongue appears normal. Chest wall normal. No rachitic rosary or Harrison sulcus. There is no rashes or neurocutaneous markers. Neck: there is no swelling with normal external genitalia, no hernia. Spine: there is no kyphoscoliosis, no tuft of hair or sacral pit or any abnormal swelling. Fingers and toes: there is no asymmetry. In anthropometry, weight for age. Measured is 14, expected of 18, less than -3 standard deviation. So he is underweight, severely underweight. Length for age, height for age. It's 1 or 2 centimeter. Expected is 114, less than -3 standard deviation. It is severe stunting. BMI is 13.5, between 10 to 25th centile and is normal. Head circumference of 47, less than -2 standard deviation. So it's microcephaly. And mid upper arm circumference 13 centimeter, which is normal. And on developmental assessment by 180-degree flip test, on supine position, both the upper limbs and lower limbs are flexed. On pull to sit, there is head lag. And on sitting, it is with back rounded, and on vertical suspension, scissoring of legs present. And prone position, the head does not lift off the couch. And he tries to reach objects with one hand and holds using palmar grasp. He laughs out loud. He follows objects up to 180 degree and he turns towards the source of sound. And higher mental functions, the child is alert. He is interested in surroundings and responds to commands. And on cranial nerve examination, olfactory nerves cannot be examined. And optic nerve, bilateral pupil reflex is reactive, and fundus appears normal. Third, fourth, sixth nerve, there is no ptosis, nystagmus, squint, and extraocular movement is full in all directions. Fifth nerve, there is no jaw deviation, jaw jerk is absent. Seventh, there is complete eye closure, no facial asymmetry. Eighth nerve, he responds to the source of sound. Ninth and tenth nerve, this gag reflex was normal, uvula is central. 11th nerve, he turns neck to both the sides. 12th nerve, there is no deviation of tongue or there is no fasciculations. And on motor system, bulk, there is no asymmetry between the limbs and no limb length discrepancy. And right arm bulk is 13 and the left side also 13. Forearm is both right and left is 11. Thigh, both of them are 17. And length is also both of them are 17 centimeter in the leg. And tone, there is spasticity present in all the four limbs, predominantly in the lower limb and compared to the upper limb. And there are dynamic contractures present in the elbows, knees, and ankles. And the Hamiltonian angles, the adductor angle is 90, and normal is about 110, 70 to 110. And popliteal angle is 80, dorsiflexion is 110, and scarf sign does not cross the midline. And power, best observed power is 3/5 in both the upper limb and lower limb. Mainly it is less power in the lower limb when compared to the upper limb. Reflexes, superficial reflexes, abdominal reflex is present. Bilateral plantar is extensor. Deep tendon reflex, that is biceps, triceps, knee and angle. Brisk reflexes, no angle clone is present. Primitive reflex is absent. Sensory system can appreciate pain and touch. Cerebellum, there is no nystagmus. Skull and spine skull appears small, spine is normal. And on GIT examination, per abdomen it's soft, non-tender, non-distended. There is no hepatosplenomegaly, hernial orifices are free. And on cardiovascular system, there is no cardiomegaly, S1, S2 normal, no murmur or added sounds. Respiratory system, air entry bilateral equal, normal vesicular breath sounds heard in all areas with occasional conducted sounds. So, in summary, it's a 5-year, 8-month-old male child, second child born out of non-consanguineous marriage, with history such as of perinatal insult, difficulty in sucking since birth, presented with delayed attainment of milestones, with history suggestive of intellectual disability, increased tone abnormalities, dystonic movements, no feeding difficulty, no vision or hearing impairment, with his history of poor weight gain. And on examination, the child has microcephaly, is responsive to commands, no gross vision or hearing impairment. This spasticity in bilateral upper limb and lower limb, predominantly in the lower limb, and weakness predominantly in the lower limb when compared to the upper limb, and brisk reflexes of all the four limbs, contractures present with bilateral extensor response, absent primitive reflex, chronic malnutrition, and other systems within normal limits, and no feature suggestive of regression of milestones.
Okay, so I think we'll come back to our discussion from where we stopped. Okay, now, so your main points are, you said baby was having any abnormal movements, isn't it?
Yes, sir.
Okay, so can you describe that abnormal movement, and how will you qualify that question or that abnormal movements?
So there's normal twisting movements, which is especially when the child is awake or when the child is crying, it increases on crying, and during sleep usually it reduces. I mean the.
So what are the different abnormal movements, and what could be the possibility here?
So here it could be, since it is present in, especially increased on time of cry or during pain, or when the child is awake, there is twisting movement. So it's suggestive of any rigidity or dystonia, and it is absent during sleep. Or other So other abnormal movements, it could be.
What other questions should you ask here regarding fetus dystonia? That's very important.
So during sleep, it is usually.
Is there any diurnal variation?
So during when the child is sleeping, usually it is.
What is important? What is the importance of diurnal variation for a child with dystonia? It's very important. It's a treatable condition. Yeah, that is, isn't it? Dopamine responsive dystonia or Sagawa disease, isn't it? So whenever you suspect this dystonia, you please ask the question whether
Diurnal variation.
there's a diurnal variation. Because if it is dopamine, the drug of choice is dopamine, and they will respond dramatically to dopamine. Okay. So always ask whether the child is there's a diurnal variation of dystonia. That's very important. Okay. And how to differentiate dystonia from chorea?
Chorea is so purposeless during early morning awakening.
Then
There's no increased tone is not. The tone is was normal. Perhaps it is present during early morning hours.
what can be affected in if it is if the child is having a static encephalopathy with chorea? Which other muscles will be affected? You said he is able to swallow. He's able to say acha and amma and all. If it is in chorea, what will happen? The oropharyngeal muscles also will be affected usually, isn't it? So that will significantly affect the speech. So that answer is very important here. Okay. Right. Then we discuss about the CPMX. I think Sir also mentioned regarding that. And you said regarding the spasticity, but you didn't mention the how will you grade spasticity? That's also very important here, because rehabilitation is of prime importance in this child. How do you
So
grade spasticity?
modified Ashworth scale, sir.
Yeah.
So one is
How many grades are there? And what's the grade in upper limb and what's the grade in lower limb?
sir in
Okay, I think you have mentioned. I think you always remember to whenever you comment on spasticity, please comment on the grade it, because that is very, very important for rehabilitation. Okay, modified Ashworth scale is the thing, right? Then you said that it is dynamic contracture, right?
sir, it is you're able to move the limb to the functional position, normal.
Oh, right.
The ankles and the knees.
Do you want to mention any other scale here before completing the going to the investigation?
Scale for motor systems.
Yeah. Which scale will you apply here? Or what are the scales that we are aware of?
So there is screening development.
No, that's a gross motor.
Gross motor function.
So I think as a part of this, I think you should always mention the gross motor function classification system, isn't it? And also the manual. What is MACS?
Manual ability classification scale.
Yeah, manual ability classification. So I think that whenever you discuss such a baby with the features probably sized of a static disorder, I think you should always mention these two, because that is very important rehabilitation as well as in giving disability certificate. Okay, because we decide the disability based on these classes: gross motor function classification system as well as manual ability classification system. And do you want to apply one more scale, keeping in mind activities of daily living?
So eating and drinking. Eating and
Is there a
drinking.
scale? Is there a recommended scale for such children?
Yes, EDACS, eating drinking ability classification scale.
Okay. Eat and drink classification, or there's another that's also called FIM. functional independent measurement. Okay. So I think only I think you have to mention these scales also before conclusion. Okay. Right. So have you classified it or have you looked
Yes, sir.
into this?
I've classified it. Yes, sir.
Okay, well, you can show that also.
So, so
So scale 5, MSCS 4 and
G-
EDSCS.
5 MSCS of grade 4, EDACS of grade 5.
Right. Okay. So now, sir, any more comments or we'll go to the differential diagnosis?
Anuja,
Yes, sir.
the neurological examination of a developmental delay is not the same pattern as other neurological problems in pediatrics, like when you are getting an acquired ataxia or an ICSOD or demyelination or whatever. The CNS examination, you try to localize the lesion, anatomical reasons, pathological basis, and that sort of. Here, you're not spending too much on this thing, but many other points are assessed during your examination. It's a continuation of what you have assessed in the history, in the general examination, in the neurological examination. Basically, it's all for planning the management. The parents concerned, what can I do? What can be done for my child on a long-term basis? You are joining with the parent or the planning. So those points are the ones which are needed in the evaluation. You started from the history. In the general examination, again, you need to answer those questions. Is there any clue that it is unlikely to be a CP, another condition which may mimic a CP? There can be a clues in the general examination. There are a few conditions like diplegia. It can be arginase deficiency. There are other conditions also. So general examination can give a clue for that. That is the one thing. For example, the situation of a mixed CP with a chorea. It can be a glutaric aciduria. So that sort of a situation, there can be clues in the general examination in the hair or a skin or something. So that point onwards, your possibility deviates and the prognostication management, everything will be different. So that is one point in the general examination. There are second thing in the head foot examination is assessing prognostication for the severity and the planning. In this case, Hari was pointing out a very eminently treatable situation when you said a dystonia is there. In this case, it's unlikely because there is significant involvement in the multiple milestones. Gross motor is significantly involved. It's not only fine motor, social, language, microcephaly. So even when dopamine can do something, but it cannot be totally reversing like your dopa sensitive dystonia. So those things starting from the head circumference is very important prognostically. And when you come down each of the points in the eye, vision, fundus, cataract, squint, because you are planning the management. I don't have anything much to do for the ocular part, except one thing, cerebral visual impairment. In this case, with the significant higher function and problem and all, it may not be easy to assess the CVI situation. So that is, these are all need to be considered in a case. Ophthalmology is a multiple, it's a little extension of the ophthalmological part in a case of a CP. CVI comes there, it is under recognized nowadays. Then comes the down thing. All the assessment of the functional assessment are important. That is not there in your acquired neurological problem. Here, Hari was pointing out gross motor function impairment, MAC, TAC, all those things are very important in this evaluation. Here comes your history a little bit misleading. Actually, this patient with this much of GMFCS will be using CP chair or wheelchair or totally dependent situation. That was not the impression when I heard the history part. Child was going to school and all. So it's a totally dependent, most probably in the wheelchair only. So that was not coming in the history part. So all the evaluation, the functional scales need to be answered, especially the feeding part. In this case, there is not only spasm, there is dystonia also. There can be both ways the feeding involved. You didn't mention about those things. Drooling is important. So what about the oromotor movement? How much time the mother takes for the feeding? Because caregiver burden is another important thing. So lot of discussion of the social aspect will be there in the CP and development delay problems. So all those things need to be given importance. When you go down about the deformity assessment, you mentioned about the spine, about the chest deformity part, about the hip and hip you mentioned. Okay, there can be a different Windsor deformity, all those are deformity assessment, contractures, bed sores, skin changes, micronutrient deficiency. You mentioned about the vitamin A and all. But all those things, infections, infestations, and how much care the baby is getting from the parents. It can be a neglected child, it can be malnutrition, micronutrient deficiency, obesity, all those things. So, many points in the general examinations are important. The neurological examination, Hari was pointing out, you mentioned about the dystonia part, but when you're mentioning about the tone, there is another thing. What do you expect in the tone? It can be a combination. The pyramidal and extra pyramidal also is likely. So that also need to be considering when you examine the neurological part. So it should be much vaster in your evaluation. Development delay is such a vast topic, not only neurology, it is touching on many other parts, especially social pediatrics. Okay, Hari, you can go ahead.
Okay, thank you, sir. I think, okay, now I think we'll go to the investigation and the management, because the management and rehabilitation is very, very important in such a child, isn't it? Okay.
Yes.
Okay, Anuja, proceed. How will you evaluate this child and how are you going to rehabilitate this child?
So for investigations, you can do hemoglobin to look for any features of anemia or any source of complete blood count can be done. Or then, so CP is usually a clinical diagnosis. You can do brain imagings to rule out other etiologies. Like, so you can look for any features of asphyxia or any other cause of other CP mimics. To find the etiology, we can do brain imaging, and even you can do ophthalmic and hearing evaluation. And since he's a child with developmental delay, even you can do thyroid function test. So then, if you suspect CP mimics, you can do metabolic workup for the child with CP, and it is urine metabolic screening can be done. So then, for these are few investigations to be done, and for rehabilitation, it requires a multidisciplinary approach. And for this child, first and foremost, important is physiotherapy, which requires both pharmacological or non-pharmacological. And physiotherapy is necessary to improve the muscle strength, to reduce the spasticity, and to prevent the disability and to improve the quality of life in the child. And they can be even pharmacological measures, like you can use baclofen or diazepam can be used. And if selected specific muscles, even IM botulinum toxin can be given. Then the child is having drooling of saliva, so you can give oromotor stimulation for the child, and anticholinergics to reduce the, like glycopyrrolate can be given to reduce the secretions. Then even important is visual and hearing stimulation must be given. Then then you can give certain or certain assist devices like orthotics devices or braces or casts can be put, so that to prevent the contractures, like foot orthotics or can be given for rehabilitation. Then for neurodevelopmental, you can give like you can give, since the child is able to sit with the mother's help, so you can give certain CP chairs for the child, and it is to improve the activities of daily living in the child, that is for to improve the feeding, and then speech therapy for the child. There is then you can test the IQ of the child, and there's this disability certificate can be given for this child, and certain financial benefits like this is the cerebral palsy. There is certain schemes they can be given for the child, and
Okay, I think we'll come back with your investigation. Okay, so you said, do you want to go for urine metabolic screen for this child at this juncture?
so
Do
since
you
it is,
think this is likely to be a CP mimic?
there's no regression of milestones or other features. There's no progressive
As I was
worsening.
asking, any head to foot examination, any findings?
No, head to foot. So there is no findings. No, there's no organomegaly. There is no other hair.
Okay.
There's no eye abnormalities. No neurocutaneous markers. No feature suggestive of.
Okay. So practically speaking, it's likely to be cerebral palsy, isn't it? So I think we had to focus mainly on the rehabilitation, and as much as possible, occupational rehab. That's very important when not possible. So I think the most important point to be stressed is, one, we had to grade already, as we said, we had to grade the spasticity, and you should know what are the conditions that will aggravate the spasticity. Okay. So what are the situations where the spasticity will be aggravated? That is, in all chronic disease, the one head
Sir, when there
correctly
is
correctable non-pharmacological and pharmacological measures. So what are the correctable measures when you deal with the spasticity in a child? Anyone? Okay. I think one is infection. Okay. So even if it is dental caries, I think almost probably more than 90 or almost 100% of children with cerebral palsy will have dental caries. So we have to address the dental caries, because that will act as a source of infection that will lead on to major infection. So always address the dental caries and correct all the dental procedures. And all infections should be treated very promptly, because infection, presence of fever per se, any pain in such children, all this will aggravate spasticity. Okay. So these are the correctable measures. So we have to take care of all these aspects, very, very important. Then the then you mentioned the non-formal measure, that is the stretching exercises, massage, and also the physiotherapy. But according to you, the gross motor function class system is grade 5. That means he has got almost probably severe spasticity. In such a child, it's always better to bring down the spasticity and start physio. Otherwise, once you get physio, the pain will be aggravated, and that will lead on to more spasticity. So that is very, very important. And as you rightly said, you can put the baby on a diazepam plus baclofen. And if not helping, you can also go for tizanidine. Okay, so these are the three drugs given: diazepam, baclofen, and tizanidine. You can titrate the drug, because please remember that baclofen will reduce the seizure threshold. Okay, so and also it is very important to give one dose of paracetamol about 1 hour before giving physio, because that will alleviate the pain to a major extent. So that is how you should start physio. Bring down the spasticity to a controllable limit, then give paracetamol and give diazepam also 1 hour before the procedure, and then you start physio. And you must always fix your level of rehabilitation, because in rehabilitation, especially in children with cerebral palsy, there is an accepted level of spasticity, because some children or aim may be locomotion. Some children are aim may be just making the child stand. In some children, it may be just toileting. So depending upon that, we have to fix our. So that is a accepted level of spasticity depending upon the condition of the child. So I think that means the rehabilitation or bring down on the spasticity in children with cerebral palsy depends upon our level of occupational rehabilitation that is achievable. Okay. And then you said regarding the botulinum toxin, and what's the program under which we can give local injection botulinum toxin free of cost to children? Is there any program, national program? Anybody? That's called the Niramaya program. Okay. So there's actually we were giving in SAT also. Okay. So it is the Niramaya program where the children are given 1 lakh per year. That's by the central government. And under this, we can give local injection botulinum toxin. And if it lasts for about 3 to 6 months. So that is regarding the spasticity. Regarding dystonia, I think we already mentioned, as I was also mentioning. So always we can always go for a trial of L-DOPA. Because, isn't it? Because this is not a Sagawa disease, but we can always go for a trial of L-DOPA. And what are other drugs given for dystonia?
Trihexyphenidyl.
Yeah, trihexyphenidyl, benztropine, as well as nitrazepam. Okay, so these are the drugs that can be given, and we can control dystonia with a major. Then you said the excess secretions can be controlled with hormone exercises as well as glycopyrrolate. Is there any very cheap drug that can be given for such children to control the excess secretion? I think we can give the homotropin eye drops. Okay, I think it is a internationally accepted module where the homotropin eye drops that is applied in the eyes by the ophthalmologist for palpation can be given for such children. A few drops of homotropin will solve the matter, and the mothers find it very, very easy to administer also. Okay, so I think keep in mind, whenever we come across such chronic children, to control excess secretion, we can go for glycopyrrolate, but it's not available, you can go for homotropin eye drops. Okay. Then what are the drugs that can precipitate dystonia? Because these drugs should be avoided in such children. Drugs that can cause dystonia. Anyone? All these are very, very practical points. Drugs causing dystonia.
Sir, metoclopramide.
Yeah, metoclopramide. Then anticonvulsant, phenytoin, carbamazepine, gabapentin, risperidone. I think we should know because these are common drugs that is given in children, isn't it? So always, if possible, we had to avoid such. Right. Now, you said regarding disability certificate. How will you assess the disability of the child, and how will you assess give the certificate? Because you know that pediatricians are included in the disability board. So once you pass out, you will be included in the disability board, and you are responsible to give a disability certificate. So how will you give disability certificate for this child?
So there are IQ scales, like, sir, there is.
Will you be able to assess the IQ for this child?
This the second form board.
Will you be able to assess the IQ?
So, the social.
What will you do? If you're not able to assess the IQ, what can, as you said, you can assess the social quotient, isn't it?
Social quotient.
Yeah, you can assess the inline adaptive behavioral scale to assess social quotient, and practical purposes, social quotient into 0.8 is IQ. Okay, that is one method. Okay, then what will you do? Or what is the basic principle in giving disability certificate? I think all pediatricians in India should know this.
There's the
See, this child is having multiple disabilities. Child is having locomotor disability. Child is having vision impairment. Child is having hearing impairment. Child is having intellectual disability. So you have to calculate all these disabilities, and there's an equation to find out multiple disability in such a child. Okay, so it is our responsibility to calculate all these multiple disabilities and to apply that formula and find out the total disability and give the disability certificate. And since this child is rehabilitatable, never give a child is growing, it is a static decision. So child may improve. So always you give a temporary certificate. Never give a permanent disability certificate for children, because all these are very, very important. Okay. And what do you mean by benchmark disability? Anybody, what do you mean by benchmark disability? And what's important? Yes, the 40%, isn't it? Because children with the 40% of above disability are likely to have great advantages and great reserves. They can 4% of all professional, including professional seats, as well as 4% of job opportunities are reserved for person with a disability. That's very important. So I think we should always find out the exact disability and then issue the certificate. Otherwise, it can cause problems also. Now, how will you counsel this mother? What do you think the prognosis, and how will you counsel the mother?
So since the child is since the child is responsive, he's responsive to commands, he appears grossly visual and hearing is normal, you can advise the mother to continue physiotherapy and um, um, then to continue stimulation exercises, visual hearing exercises, and proper with adequate nutritional therapy, and the, with continuous physiotherapy, child is like, if it since it's static encephalopathy, child is likely to improve with physiotherapy, sir.
Any other advice will you give?
So then
Other than
immunization must be
yeah.
And mm, nutritional immunization.
Is there any other scheme for such children?
What is so there's a Nirayamas. Niramayas.
Niramaya, anything else? I think you should be aware of the various schemes under the central government as well as state government. I will just mention what is ADIP scheme. Anyone else? Anyone? ADIP.
So activities of daily living.
You can go back and read. ADIP means assistance to disabled persons. Okay, and there are a lot of programs under the national trust like the Disha, Vikas, Jana Prabha, Niramaya, etc. I think all these will be beneficial in children with such children with the chronic disabilities, and this will be of great help. And regarding the prognosis, what is your comment? GMCS of grade 5 is a grade sentence. So I think the is he completely bedridden, or is he able to get up and
So he's not
stand?
able to. No, sir. He's not able to get up on his own. He's with the support. He is able to sit. Otherwise,
Okay.
he's not able to. Only
Right.
partial head control is also attained.
Okay. So as Srinivas are mentioning, I think it's saying, so generally, so we should plan physiotherapy. We should plan occupational rehabilitation, and occupational rehabilitation, the focus either it can be occupational rehabilitation, or it can be locomotion, or it can be activities of daily life, or it can be toileting. So depending upon the condition, we have to decide our level of occupational rehabilitation. That is very, very important. And nutrition assessment is very important. And always give all immunization, including probably yearly influenza vaccine also, because as we mentioned earlier, any infection can aggravate all this spasticity and dystonia and all. So, if possible, give all the vaccines as per UIP, as well as also give influenza vaccine. Okay, because the seasonal flu is one reason for repeated hospitalization for such a CP children. Okay, and as I mentioned, we had to go for a disability certificate and include them under all the state and the national programs so that the child will get the maximum benefit. Okay, right. Sir, Purushottam sir.
Excellent discussion. Anuja,
Yes, sir.
in the 180-degree flipping,
Yes, sir.
when you're holding pull to sit, there was a total lag.
So there's
Okay.
total.
There was a lag in the neck.
Partial.
That is what you mentioned. In the vertical suspension, there was scissoring. Okay. Then you went for the prone position. So we are interested also in the 180-degree flipping is from pull to sit, vertical suspension, and ventral suspension, then only prone position. In the ventral suspension, you expect the neck to be a little overextended.
Yes, sir.
Because that is the situation. When a spastic with the pyramidal plus extrapyramidal situation of this extent, when there is a backward, so
Sir, boy.
it's important.
Stephen.
If we mention that in the ventral suspension, then that will be usually upward. That you didn't mention in that part. That's all we'll be assessing. And in the nutritional micronutrient assessment, there is no pala, there is no vitamin. But one more very, very important thing when physiotherapy will be done for this child, the bone strength should be very significant. There are two micronutrients. One is vitamin D, of course. The other one, very likely to be missed, is vitamin C.
C, yeah.
So, in the micronutrient deficiency, vitamin D and vitamin C are very, very important. Did you do any MRI or any investigation done for this child already?
So
X-ray?
MRI was done only at the new on postal day 28. Only that, sir. Only that was the.
At present, anyway, it's not much to be done. It's not
Sir, it was done. It was done today.
today.
Just today it was done, sir. Yeah.
Interested to know whether there is any other problem also. And all the PGs, Hari was mentioning a lot of social, national program, support system for all the persons with disability. We need to know more about the RPW Act 2016, about the disability certificate given and the role of the pediatricians. And you need to know about the district early intervention centers, regional early intervention centers, what all things are being done there. What about the BUDS school situation? So it's not just passing out the examination of ND, because these are a part and parcel of your responsibilities as a pediatrician when you go out. Because these things won't be done by any super specialty people. So this is an era where everybody is going behind money, position and all. There is nobody to look after these people. So at least a few of you, when you pass out, keep an attitude just like Hari. So that's so important, because these people are also having their rights, and how much burden is for the mothers. So all these things, the present generation of would-be pediatricians need to know. There are a lot of programs. None of these PGs know these programs. That is the fact, in fact. They just want to pass out somehow by answering the questions. There are a lot of programs. We should be practicing all these things. All the pediatricians should be aware of all these programs. Hari.
Okay. Thank you, sir.
Okay. One very important point which I wanted to tell you was the constipation part and the deworming part, because this child may be brought with the excessive cry at midnight. Okay.
Yes.
I was finding for a pain and irritation, you won't be able to express it. One thing is to take the patient for the dental aspect. And the other pain may be missed fracture of clavicle, or especially in the windswept
Yes.
deformity and hip problems, dislocation of the hip, they are painful. So pain need to be addressed, and you need to consider the treatable entities of pain, and out of which the infestations, bed bug, mosquitoes, and all those things will be causing problem with their sleeping. So you need to be aware of all those things, and pinworm, very important. Okay, constipation is so common because the feeding will be only the liquid or semi-solid. Much of a fiber will not be there. So the feeding part is very, very important. What they are feeding, what are the consequences, micronutrient, fibers, and feeding leading on to aspiration, the time taken by the mother, all those things are important. Constipation need to be considered, worm trouble need to be considered. Okay, and fungal infections, infestations, perineal area are undercared. And when this is a girl child, while becoming adolescent, lot of other problems like sexual abuse. Okay, all those things are also, because it's such a social problem, it cannot be discussed in one class. Okay.
Yeah. Okay. Thank you, sir. Any other comments?
Any comments, sir? Sir was writing something, but he's not telling.
Srinivasa, sir.
Sir, unmute, sir. We can't hear you. Sir was writing something. He's the കേൾക്കണില്ലേ sir?
Srinivasa, sir.
Sir അവിടെ ഇല്ല.
സാറിന്റെ മെസ്സേജ് ഇട്ടിട്ടുണ്ടായിരുന്നല്ലോ. സാർ ഇല്ലേ?
Okay, okay.
Hello, can you hear me?
Yes, sir.
Yes, sir. Yes, sir.
Yeah,
Yes, sir.
I have already mentioned a few things. I think you discussed very well. And of course, Dr. Purushothaman has just now mentioned, there are so many avenues available for even poor patients, and they must guide them to, yeah, very nice. Excellent presentation, very good discussion. And I learned a lot. So I am here as a student more than as a former professor. Yeah.
You're always a professor, sir, not a former professor.
Thank you. Thank
Actually,
you so much.
I think the message from this discussion is like whenever you see a debilitated child, it is not just a description of the what you call the functional or the localization and all that. It is important regarding rehabilitation, and it is important for the pediatrician to know about the programs. That is very, very important. I think because I lost the connection between, I think Sir may have mentioned about the
One more point
Niramaya.
I wanted to just mention. If the
Sir, please.
discussions are going on very well, they will ask what are the various occupational physiotherapy names. It's given in 4 and so many other books. Various, what is the things. They may ask for giving extra marks and distinction.
Okay, sir.
Peto's method, Red's method, and Temple Fay method. So many methods are there. Voita's method. Yeah. Just to see whether you are attending occupational therapy during the training.
Okay, sir.
And I think REICs are there in all medical colleges, and the postgraduate should visit the REICs in between so that you can see what are the components and how it is functioning. It will be useful for you even after passing the exam, because we can either direct patients to such centers, or you can even make such centers in your hospital. So that will be a very good thing. Thank you, Hariprasad sir,
We
for
take even the undergraduates
discussing.
to attend the physiotherapy, occupational therapy department to see
Yes.
how efforts are made for people coming from all day from villages with spending money, staying there, and this thing. Okay. And one student told, how surgeon, it's not necessary to motivate us to come and show these children. He has taken it that way in the feedback, but it's very important they have, and there is excellent occupational physiotherapy unit, the amount of efforts they are taking to make these children, because those days poliomyelitis are also very common. So it's very important they must have this thing, visit and see periodically, because every medical college is having such a wonderful occupational and physiotherapy department. Thank you so much for allowing me to tell my words. Yeah.
Thank you, sir.
Bye.
Okay, bye, sir.
Bye.
Yes,
Good
please
night.
continue. Good night, sir.